Today's topic is FIGO 2025 Gestational Trophoblastic Disease. GTD, that is Gestational Trophoblastic Disease, is a group of uncommon conditions associated with pregnancy. Histologically, it includes pre-malignant and malignant. In pre-malignant, there is partial hydratidiform mole and complete hydratidiform mole. In malignant, there is invasive mole, Choriocarcinoma, placental site trophoblastic tumor and epithelial trophoblastic tumor. So this is pre-malignant condition and this is malignant condition. Now GTD also include the placental site nodule. It can be of atypical placental site nodule or placental site nodule. Placental site trophoblastic tumor, epithelial trophoblastic tumor and APSN, atypical placental site nodule, have more varied production of the pregnancy hormone, that is SCG. All other forms of GTD produce this hormone. So SCG is an excellent biomarker. Disease progression, response, subsequent post-treatment surveillance as well. Thus plateaued or rising SCG level that enables the early detection of progression of complete hydratidiform mole and partial hydratidiform mole to GTN. So risk of GTN in complete hydratidiform mole is 13 to 20%, and in partial hydratidiform mole the risk is 0.5 to 0.5% cases. Use of this biomarker together, that is SCG, with development of highly effective therapies has transformed cervical outcomes, so that today nearly all women affected by GTN expect to be cured by if managed properly. So what is the FIGO criteria for diagnosis of post-molar gestational trophoblastic neoplasia? First one is when the plateau of SCG lasts for 4 measurements over a period of 3 weeks or longer, that is on day 1, 7, 14 and 21. Second is when there is a rise in SCG for 3 consecutive weekly measurements over at least period of 2 weeks or more, that is days on 1, 7, 14. If there is a histologic diagnosis of choriocarcinoma. This is the FIGO criteria for diagnosis of post-molar GTN. What are the imaging tools for investigation of GTN? First is pelvic ultrasound with Doppler. Second is chest X-ray. So pelvic ultrasound and chest radiograph are the basic imaging tools for post-molar GTN scoring. Doppler is used to assess uterine vascularity in some centers. Chest radiographs should be used for counting the number of lung metastases to evaluate the risk score. So in chest X-ray, look how many metastasis lesion are there in lungs. So you can count, and on that basis will give the WHO score for the risk assessment. Should lung CT be used? Only metastasis of 1 centimeter or more in size are counted to evaluate the risk score. Chest X-ray shows lesion more than 1 centimeter, then you have to do lung CT scan to count the metastatic lesion for the assessment of score. Lung metastasis of 1 centimeter or more should induce a thorough imaging investigation, including contrast enhanced MRI of the brain, pelvis, abdomen or abdominal CT. So in brain, pelvis, MRI is preferred, whereas in abdomen you can do MRI or CT abdomen. Whole body imaging listed in the above bullet point is needed if choriocarcinoma, PSTT or ETT are suspected or histologically diagnosed. Characterization of ultrasound or CT scanning of suspected liver metastasis may need liver MRI. If any lesion shows in liver, then you have to do liver MRI. Brain metastasis may be diagnosed by MRI or CT. However, MRI is more sensitive than CT. Whole body scan may be helpful to identify sites of active disease for resection, either in multi-drug resistance cases or in patients with unexplained elevated SCG. Careful correlation with other imaging modalities is advised. FIGO stage is given Roman numerals. Stage 1, gestational trophoblastic tumor strictly confined to the uterine corpus within the uterus. Stage 2, tumors extending to the adnexa or to the vagina but limited to the genital structures. Stage 3, extending to lungs with or without genital tract involvement. Stage 4 is the all other metastatic sites. And WHO scoring system based on prognostic factors modified as FIGO score. This is Arabic numerals. Certain points you have to check for assessment of a FIGO score, like age group of patient. If the patient age is less than 40, then 0 score to give. If equal to or more than 40, then score 1 to give. Antecedent pregnancy. Before the GTN, what was the pregnancy? Whether it was mole, then 0 score. Whether it was abortion that leads to GTN, then score 1. If it was term pregnancy, then score 2 be given. Interval from index pregnancy in month, that is from the pregnancy to the development of GTN. Less than 4-month pregnancy, then 0. 4 to 6 month, score 1. 7 to 12 month, 2. If more than 1 year, then score 4 to give. Pre-treatment SCG value. Before you give the treatment, what was the SCG value? Less than 1000, then score 0. 1000 to 10,000, score 1. 10,000 to 1 lakh, score 2. More than 1 lakh, score 4. Largest tumor size, including uterus. If 3 to 4 centimeter, then score 1 to give. If more than or equal to 5 centimeter, then score to give. Site of metastasis, including the uterus. Lung involvement gives score 0. Spleen kidney involvement gives score 1. GI tract involvement gives 2. Brain or liver, then score 4. Number of metastases identified. 1 to 4 metastases, score 1. 5 to 8 metastases, score 2. More than 8 metastases, score 4. Previous failed chemotherapy. Single drug failed, then score 2. 2 or more drugs failed, then score 4 is to give. To stage and allot a risk factor score. A patient's diagnosis is allocated to a stage as represented by Roman numerals that we have already seen. 1, 2, 3, 4. Stage 1, stage 2, stage 3, stage 4. This is then separated by a column from sum of all the actual risk factor scores expressed in Arabic numerals. For example, if a patient came and you evaluated her, then the stage came as stage 2 and the score came as 4. So you write it as stage 2-4. If the stage come as 4 and score came 9, so you write it as stage 4 and score is 9. This stage and score will be allotted for each patient. Abnormalities of gametogenesis and fertilization are more frequent at the extremities of reproductive age group and can explain the higher prevalence of hydatidiform mole among teenage girls and women older than 35 years. Teenage girls and women over 35 years have twice the risk of having a sporadic mole compared to that women age group between 20 to 35 years, and the risk increased 5 to 7 times for women aged over 40 years. Prior mole pregnancy increased the risk to 10 times for sporadic complete mole, while familial clustering and recurrent mole is the rule in familial biparental recurrent moles due to mutations of NLRP7 and KST-C3L genes. Risk of recurrence after complete mole is approximately 1%, which is not seen after partial mole. PSTT and ATT, placental site trophoblastic tumor and epithelial trophoblastic tumor, are the rarest type of GTD. Incidence is 0.2% of all GTD cases and 1 to 2% of GTN cases. Molar pregnancy. Grossly complete hydatidiform mole consists of hydropic villi to semi-transparent vesicles of a variable size with absence of normal placenta. Early complete hydatidiform mole may have minimal or no gross evidence of abnormal villi, and differential diagnosis of complete mole include partial hydatidiform mole, hydropic abortion, early non-molar gestation with florid trophoblastic hyperplasia. And WHO classification introduced a new category of abnormal villous lesions that carry the same low risk of GTN as other non-molar conceptions. In the absence of genotyping studies, women in whom partial hydatidiform mole is suspected because of the presence of atypical or dysmorphic villous morphology may be monitored by ECG surveillance. Histologically, complete mole has florid cistern formation, trophoblastic proliferation, and absence of fetal parts. Significant cytological atypia and mitotic figures may be seen. In the first trimester, complete mole villi may not be marked enlarged but have a distinct polypoid appearance with abnormal bilious stromal changes and mild to moderate trophoblastic hyperplasia. In contrast, such histologic features are less marked in partial mole, and fetal part or cells are present in partial mole. Hydropic spontaneous abortion may mimic the appearance of partial mole. Cyclin-dependent kinase inhibitor P57. It is encoded by the paternally imprinted and maternally expressed gene, hence is absent in the villous cytotrophoblast and stromal cells of complete mole without the maternal genome. So in complete mole there will be no p57. In contrast, partial hydatidiform mole and non-molar abnormal gestation with maternal genome have strong nuclear p57 staining, which can be used to exclude complete mole. So partial hydatidiform mole and non-molar abnormal gestation with maternal genome will be having p57 positive nuclear staining. However, p57 cannot differentiate partial hydatidiform mole from non-molar gestation. Cytogenetics of complete mole, partial mole and hydropic spontaneous abortion are different because complete mole is diploid as 46 XX chromosomes with both X chromosomes from paternal origin. There is no maternal data, so there is no p57. Whereas in partial mole, it is triploid with maternal and paternal genetic origin, so there will be p57 nuclear staining. Hydropic spontaneous abortion normally has 46 XX or XY from both parents. Abnormal non-molar villus lesion may harbor various chromosomal or genetic alterations, including trisomy syndromes and Gynae triploid. So microsatellite short tandem repeat genotyping enables precise diagnosis of complete and partial hydatidiform mole by identifying the absence of maternal genetic contribution and diandric triploidy respectively. So in complete hydatidiform mole, there will be absence of maternal genetic contribution. Rarely invasive and metastatic mole can be diagnosed by hysterectomy or biopsy of a metastatic lesion. Choriocarcinoma. Grossly, the tumor is bulky with hemorrhagic and necrotic areas. Apart from the uterus, it can be found in tubes, ovaries, lung, liver, spleen, kidney, bowel or brain. Histologically, choriocarcinoma shows absence of chorionic villi and presence of proliferating intermediate trophoblast and cytotrophoblast, rimmed with syncytiotrophoblasts with areas of necrosis and hemorrhage. Genotyping analysis can identify unique paternal alleles, helping to confirm whether the tumor is of choriocarcinoma or germ cell origin or a somatic carcinoma with a trophoblast differentiation. So genotyping analysis to do. Placental site nodule. This is benign lesion composed of chorionic type intermediate trophoblast cells. It is an incidental finding in uterine or endocervical keratase specimen. Whereas atypical placental site nodule is considered a precursor to an epithelial trophoblastic tumor. 10 to 15% may coexist with or develop into PSTT or ETT. Atypical placental site nodule are larger and show more cytological atypia. Ki67 proliferation index less than 5% in placental site nodule, whereas 5 to 10% in atypical placental site nodule. Placental site trophoblastic tumor. It is a nodular masses averaging 5 cm within the endomyometrium. Approximately half of the cases, deep myometrial invasion is there. It arises from placental site extravilous intermediate trophoblast. Tumor cells, irregular nuclear membranes, hyperchromatic nuclei, and a dense eosinophilic to amphophilic cytoplasm. Most tumors have a low mitotic count. Chorionic villi are absent. Tumor cells diffusely express human placental lactogen, MUC4, HSD3B1, HLA-G, and Melcam CD146. Expression of SCG and inhibin is focal. Tumor cells diffusely express different markers. The proliferation index, that is Ki67, is generally increased with Ki67 expressed in 20 to 30% of cells, higher than that of benign exaggerated placental site reaction. PSTT shows rare genetic imbalances. Epithelial trophoblastic tumor, discrete nodules or cystic hemorrhage masses invading deep into the surrounding tissues. Nearly half arises in the cervix or lower segment of the uterus, and some in fundus and broad ligament. ETT arises from the chorionic type intermediate trophoblast. Extensive or geographic necrosis is often present. ETT may coexist with other trophoblastic neoplasms. Ki67 proliferation index is greater than 10%. ETT may mimic choriocarcinoma, especially after chemotherapy, PSTT, and squamous cell carcinoma of the cervix. Clinical presentation, investigation, and diagnosis. Molar pregnancy. Patients usually present with second trimester vaginal bleeding, as diagnosis is often made in the first trimester with ultrasound examination Complications such as hyperemesis gravidarum, preeclampsia, and hyperthyroidism less common. If there is vaginal passage of gestational product, vesicles may be seen. The typical honeycomb appearance of a complete mole in ultrasound is rarely seen, especially in the first trimester. Typically, there is absence of fetal parts and cystic appearance of the center, absent in complete mole. Hence, molar pregnancies should be diagnosed on histologic examinations after evacuation for a spontaneous abortion or a suspected molar pregnancy. Gestational trophoblastic neoplasia. Post-molar GTN is usually diagnosed by ECG surveillance without symptoms. So ECG monitoring, human chorionic gonadotropin monitoring. For monitoring of GTN and ECG assay that can detect all forms of ECG, including what are the variety of ECG, beta ECG, core ECG, C-terminal ECG, negative-free beta, beta core, and preferably the hyperglycosylated forms should be used when possible. A persistently low ECG level needs continuous monitoring, as some may progress to GTN with rising ECG levels. To exclude false positive result, retest with another assay kit or a test for urine ECG may be used. GTN after non-molar pregnancy. About 75% of GTN follows molar pregnancy, whereas 25% after a spontaneous abortion, ectopic pregnancy, or a term pregnancy. So 75% after mole and 25% after non-molar pregnancy. Aside from postpartum abnormal vaginal bleeding, other clinical presentation can include bleeding from metastatic site such as the liver, spleen, intestine, lung, brain, pulmonary symptom, and the neurological sign from spine or brain metastasis. GTN should be considered in the differential diagnosis of patients with unusual presentation, and serum ECG should be performed as a part of the workup of such patients. In case of suspected post-term pregnancy GTN, imaging studies should include contrast-enhanced MRI pelvis, contrast-enhanced MRI brain, CT chest, and abdominal CT or MRI.